What is your diagnosis? My diagnosis is 25-year-old male, chronic osteomyelitis, the right tibia, 2 years old, with equinus, cause post-traumatic, with non-union of the fractured tibia. Why do you say so? This 25-year-old male sustained injury due to road traffic accident 2 years back. He had pain, swelling, deformity and loss of function around the right upper leg with a wound, without a wound or any neurovascular deficit. He was managed by reduction setting and immobilization by above knee plaster for 45 days. After the plaster was removed, he was unable to bear weight and had immobilization by external fixator from 2020 to 2022. There was always a discharging sinus since 1.5 years. The fixator was removed and below knee POP was given and the tibia was exposed. Full thickness skin grafting was done. However, discharge with bone spicules persisted. On examination, the general and systemic examination are non-complementary. Local examination reveals a full thickness skin graft with epithelialization across the skin of tibia and a discharging sinus fixed to bone. There is localized tenderness and proximal to the single sinus that we see, there is no evidence of collection, drainage, enlarged draining lymph nodes. The margin, edge and floor of the sinus cannot be commented on. The sinus is fixed to its base, that is the bone. There is no sprouting granulation tissue. Weight bearing is not possible. Abnormal mobility is present above the sinus. Transmitted movements are partially lost. There is tenderness at the site of above the sinus on thumping the heel. There is equinus at the ankle. There is swelling over the right foot. There are multiple scars on the foot. And there is no neurovascular deficit. My clinical diagnosis is 25-year-old with chronic osteomyelitis right tibia with non-union, 2 years old with equinus, cause road traffic accident, and the fractured tibia has not united. So, how would you investigate? I would like to assess the general condition of patient by hemoglobin, TLC, DLC, ESR, GBP, BTCT, blood urea, blood sugar, HB1AC, urine, stool, LFT, and viral markers. I would rule out specially amyloidosis. Then I will image the lesion, X-ray of the right leg, including everything from knee to toe, and this would be AP lateral. Then I may do a sinogram, but I don't think there is any cavity inside. And finally, I will determine the microbiological status by a culture and sensitivity. How would you manage? I will read the X-ray for sequestrum, cavity, cloacae and non-union, and I will try to assess the angle of the equinus. To decide the management of the equinus, then I will determine the culture and sensitivity. I will look for creatinine and urea to rule out amyloidosis. And if this is the X-ray of the right leg with fracture of the tibia and fibular shaft, there is no trabeculae across the fracture line. The fracture margins are smooth. This was a double fracture and the proximal one has not united. There is cortical thickening and irregularity. There is presence of sequestrum and cavity. The fracture fibula appears to have malunited. There is no soft tissue shadow. What is your plan of management? Under the general anesthesia or spinal anesthesia with patient supine and part preparation and draping done, I will expose the fracture. I will saucerize the cavity and do a sequestrectomy. I will remove all dead bone and will place a cement spacer with antibiotics as per culture and sensitivity to maintain the space between the bones. I will preferably immobilize by Elizarov, where I can have the option of doing a bone transport. After the wound heals and there's no infection for about 6 months, the spacer would be removed. And if Elizarov has not been used for docking, then I would put the vascularized fibular graft to fill the tibial gap. Then I will give a heel raise to manage the equinus. I feel that the healing of infection, the prognosis is 70%, chance of union is about 40%, and chance of walking without support is only about 30%. So this finishes the case presentation.